Basically, the most common lesions we find are on the medial femoral condyle. The most common, the second most common is the lateral femoral condyle, the lesions. Then comes patella, and then comes the tibial surface. So what are the advantages of OATS? Most importantly, OAT gives you a complete bone and cartilage, which gives structural support and durability. It is in single stage surgery. That is what is very important vis-a-vis compared to MACI or AC, where it's a two-stage procedure. It is very cost effective. The instruments are reusable. It's a very lower, the expenses are very lower, and you do not require any high-end labs to manufacture or culture your cells and provide them to you. Hyaline cartilage, as we all know, we all as cartilage surgeons want hyaline cartilage to come to the area of a chondral damage. Hyaline cartilage will be there, and it's a structure that addresses the whole tissue transfer. So if there is subchondral involvement, you get a chondral surface as well as a subchondral involvement in that. There are certain disadvantages also for the osteochondral autograft transplantation. Firstly, initially, it is a technically challenging procedure, especially if you want to do it arthroscopically. It can accommodate not more than 4 centimeter lesion square, but usually, as of now, the latest algorithm says that up to 2 centimeter square lesions can be accommodated. The main reason for this is because there's a lot of donor side mobility, and you've got a limited supply from the donor side because you are harvesting the patient's own osteochondral unit. So going back to 2003 and Hangodi and Fuels, they published a result of 893 patients in which they found that, and they followed them for 10 years, and they recommended that there were excellent results in the femoral condylar area. Patella and trochlea was the bad child in the room, which was 79%. They got good results for a low volume of tibial condylar transfers and even for talar osteochondral lesions. They used to patella. We went on, as you can see over here, there's a large patellar chondral defect over there, which was seen on the arthroscopy. This was the osteochondral fragment. We tried to retrieve it, but it was quite fragmented, so we couldn't put it back. And then this is what we did. So we put in two plugs over there. One was a 6, two was 6, and one was an 8 plug in the mid to lower pole of the patella. And along with that, we did an MPFL reconstruction also on that same patient. And this is the clinical picture or the clinical movement of the patient after 8 years follow-up. Another patient, 32 years male, recurrent knee pain, arthritis, effusion, all sports. We tried all conservative treatment. And those were the days when, we were doing more of open procedures for OATS. And we put in 3 plugs. And this patient has been doing well. I've followed up this patient for more than 4 years. And this patient has returned back to all his activities. So again, now, as we said, we have to start on, kind of improving our techniques. So we started with doing the OATS. So again, how do we do an OATS procedure? The first and foremost is you need to have a very good portal. The fat pad needs to be cleared. You need to identify your portals. You need to identify the curvatures. You need to make a mental map as to where your lesion lies and where would you get the osteochondral allograft OATS graft from, and how would you position it. So mental mapping is very important. If you can't, then you need to draw it on your board, which is available. As you can see, this is a loose osteochondral fragment over here. So proper portal placement, clearing up all the fat pad, very important. And more importantly is you need to make a mental map to understand how you're going to harvest and how you're going to place it. So, so again, what we do usually is, this is the bony tamp which we use. So we can use this bony tamp, or we can even use the harvester to kind of make a map as to how many plugs you'll require, what is the size of the plugs you'll require. Again, all this is arthroscopic. So you need to really flex and extend the knee and adjust your scope and have a 360-degree view of the coverage that you're going to get. So how do we get it from the donor side? So again, you need to extend the knee. Once you've extended the knee, I would usually go up to 13 mm of my extraction, because then the 2 mm is for the cartilage that is there. And my recipient side would go up to 15 mm. So I would try to achieve a flush plug. More importantly is that you need to understand that which part of the condyle you are taking the plug from. So that condyle, the curvature of the condyle needs to match the curvature, because even if your plug, as per the studies show, that if your plug is more than 2 mm proud, it is a sure shot cause for failure. So what we'll do is that once we go the recipient area, we will drill it up to 13 mm plus the 2 mm for the cartilage. And again, you need to be very parallel. You need to be completely in line, and your scope should move around, because you might have a reading on this part which will show you 13 mm, but on the undersurface you might have 12 or 11 mm, and that will lead to a improper placement of your OATS plug. So a 360-degree view of your the harvester has to be very important. So we go ahead, and then what usually we'll do is you will push in the plug, because there is these instruments have a screw-in mechanism. You can put in there, and I will kind of screw it in. The last few millimeters, I would not screw it in. I would prefer to use the tamp so that this big instrument is not blocking my view. So once I'm done with this, I will remove the inserter, and then I'll use my tamp, and then I will slowly put in my graft. So this is a case where we have done 2 plugs, as you can see over here, and slowly you need to tamp it in so that you get a very flush fit with the chondral surface. And that is where you will find that, the healing rates, the patient satisfaction rates, and the return to pre-injury levels are very good. So again, being flush is very, very important in such cases. And previously, when we were there and I visited Dr. Hangodi in Budapest, I requested him to show me the results of his work. And this is something that really, I was sold to this idea of osteochondral autograft transfer. And these are videos which he has compared, right, starting from 4 months. This is a 1 year post-op, as you can see. Very well integration of multiple plugs he has done. This was, I think so, a 3.5 centimeter square lesion. And if you look at the harvest site, you can see that there are no chondral changes on the patellar surface also. And this harvest site is filled with a lot of fibrocartilage. Usually what I'll do is from the recipient site, I will use the bone plug. I'll cut the bone plug and put it back into the graft harvest site. This is another case, which is a 5-year post-op. As you can see, with 5-year post-op, such beautiful results, no chondral changes on the tibia, no meniscal injuries. And this is something for the talus. So moving ahead, the literature which we came across recently, this is a paper published in 2024, shows that even for soccer players up to 25 years, I do understand that, long-term results of 25 years are even not good with total knee replacement. But osteochondral autologous transplantation in soccer players is very good for small to medium-sized defects. So the take-home message that I would want to give to all our listeners today is that osteochondral allograft transfer is a viable and a reproducible option. The instrumentation is very easy. It's a low learning curve, especially for the open procedure. The arthroscopic procedure, once you get used to it, you start using it, you might make some mistakes here and there, but it's not a very steep learning curve. It's challenging, but you can always do it. We always need to understand the dynamics and the orientation of the port placement, as well as the placement of the graft. That is the key to your success. It is not open or a closed procedure. And again, a recessed graft by 1 millimeter is always better than a proud graft. So you need to measure your notches, you need to measure exactly, and you need to have a 360-degree view of your graft as you are putting it in to understand that there is no mismatch. And definitely we have seen very good long-term results up to 15 years. And definitely that is the reason why even for patellar cases, osteochondral autologous transplantation is a good option, a reproducible option, and an option that can give really long-term results. Thank you very much.
Thank you very much, Dr. Rahul. That was a very clear presentation. Just to help the young surgeons, can you give a few tips and tricks for people who like to change over from a mini open osteoarticular transplant surgery to arthroscopic?
See, that again, as I said in my video, that the first thing is a proper portal placement. You need to actually place the port in a proper, and you need to probably make the port a little larger, because these instruments are, sometimes you might even end up using a single plug, which is 10 mm. So these instruments are quite big. A minimum size that you'd use is 6 to 8 mm. So these instruments are big. You need to put in the TAMPs, you need to put in the scope. So you need to have a larger port. The fat pad should not be obscuring. And again, as I said, so once you enter inside, your scope should rotate around all to see, because if you need to understand that it's a curvature. The condyle is a curved. The trochlea and the lateral sulcus area where you're getting the graft from is probably a little flatter area than the condyle. So as you keep on going deeper into the posterior parts of the condyles, it becomes more curved. So for you to put in a plug, a near flat plug into a curved area, you probably need to rotate your scope and see from all the sides that the markings that have been on the instrumentation, if it is 10 mm here, initially we would have a 10 mm here and an 8 mm over here. So you need to rotate your scope around, probably to see that you're clearing the area that you want to do completely. And secondly, you need to be very gentle. In case you have a problem that you understand that probably the graft is little longer on one side, you can trim off the subchondral bone so that you can fit it in. But again, sometimes because all these osteochondral grafts are press fit. So there is no fixation required. So the moment you tamp them in completely, it will be a completely press fit, and retrieving that graft, if there's a mismatch, is going to be difficult. So check, recheck, and recheck. There is a ruler. There is a ruler which is available with the instrument set, which is a kind of a circular ruler which will go inside. And again, you need to assess with that ruler that you are going to place the graft very, very properly. Patience is required in the initial first few 8 to 10 surgeries. But once you start, getting the hang of it, probably that is where you will start being more comfortable, because, then there are no stitches, then there is no hemarthrosis, the patient goes back, there is no suture removals, nothing. So it becomes a completely closed procedure. I did struggle initially. I would say surgeons will tunnel mismatch. There was some amount of plug mismatch. But once you start getting the hang of it, you'll get it. But again, the knee needs to be flexed and extend. So for harvesting the graft from the lateral areas or the medial areas, you need to extend the graft so that you get a perpendicular. And again, implantation or removing of the graft, you need to be perpendicular. Always remember, you need to be perpendicular so that always your graft sits flush. And then probably once we go to the question and answer sessions, again, we would have many more questions coming up. Okay.
So Dr. Rahul, excellent presentation. And you have shown us very nice cases also. So which are the typical indications and which are the absolute contraindication for this surgery? When we compare it to the other surgeries.
Definitely. So as in for all chondral surgeries, for all cartilage surgeries, the typical indications are, the best patient would be a young patient, a patient with low BMI, a patient who has a high pre-injury activity level, a patient who has got a small contained defect, so that you got a shoulder on all the sides. Because putting a plug in an uncontained defect is not going to be easy. So you need a completely contained defect, so that there is no fibrocartilage growing between the implanted plug and the native cartilage. But sometimes if you got a larger defect, definitely you will not be able to fit in all you'll not be able to cover in all the areas, because taking a 10 mm plug or a larger plug will definitely lead to some donor site morbidity and the limited availability of the plugs. So usually, as per the literature, it says that you need to have at least minimum 80% coverage of the defect. So if you get an 80% coverage of the defect, the remaining areas will fill with fibrocartilage and you'll be able to get away with it. Now, coming to the contraindications, definitely a global disease, let's say rheumatoid disease, or a patient who's heavy BMI, a patient who's a smoker, has got osteoporosis. All these patients, the outcomes are not going to be great. The second part of that question answer is that patellochondral defects, yes, patella any which ways, whatever kind of chondral procedure you do for a patella doesn't behave the way we want it to behave. It doesn't behave the way the medial femoral condyle or the lateral femoral condyle behaves. So for patellochondral defects, you need to be very careful, because the subchondral plate in the patella is quite thick. So matching that subchondral plate, because actually the healing is going to happen at the subchondral plate area. And that is the structural place which is going to give you the maximum structural stability for your, because the rest is only porous cancellous bone. So yes, these are the contraindications that I would, and a patient who has got, is not very active, I would not want to do such a precise procedure. Any other marrow stimulation procedures, or as we have got the or regenerative procedures, we have got the cellular procedures, those can be used for patients who are low demand and do not have to return back to a high level of sports or high level of activity.
Okay, thank you very much. Okay, thank you very much, Dr. Rahul. There is a question from the audience, Dr. Samandisuri.
Yes.
If you finally find that your graft is a bit proud, what can you do about it intraoperatively?
I do understand that's a very difficult question. Retrieving that graft, again, I would say you should not land up in that situation. If your graft is proud, you should be measuring it again, and you should be sizing your subchondral bone again and again before you implant the graft. let's suppose that for whatever reasons you land up with a proud graft, I would say you would still can go ahead with controlled tamping of that graft, because the subchondral bone is quite porous, and probably there might be some amount of, some more space that you can get in the subchondral area. But again, tamping too much or hammering too much on the chondral surface there are papers which show that there is some cell death, apoptosis that happens on the chondral surface also, and it softens the cartilage. So, and again, whenever you are tamping the graft, again, you need to be very perpendicular on tamping the graft. You cannot tamp the graft this way, you cannot tamp the graft this way, because then there'll be a lot of shear forces and you will be probably chopping off the, but if you find that the graft is quite proud, more than 2 or 3 mm proud, I suggest you discard that graft and find another graft somewhere, rather than leaving it there or struggling with it, or, kind of hammering it. And, so it's you can get at least 5 or 6 grafts from both the surfaces. So just discard that graft, leave it, and go ahead with another graft. Sometimes we had to do that because we were not used to that 360 position. We found that the grafts were oblong placed or not properly placed. So we had to abandon that graft, remove it, and then go ahead with another graft.
So Dr. Rahul,
I think the window of error for OATS is very, very low, and we need to learn the skills very well, and the steps have to be very, very clear. And I think, as you said, the only option is to redo the graft rather than doing anything else. But the very, very important misstep that should be avoided is shearing the cartilage away from the cylindrical graft, which is very much common and possible. Dr. Rajat.
Yeah, Dr. Rahul. So what is the largest size of the lesion which you are comfortable with treating with the OCT procedure? Consider it as a cartilage lesion or an osteochondral lesion. What is the largest size which we can treat very comfortably?
So, Dr. Rajat, what has happened is that now we probably the latest research is going not in terms of measuring the actual absolute size of the lesion. So we are like 4 centimeter lesion, 5 centimeter lesion, 6 centimeter lesions. Now this 4 centimeter lesion in an Asian knee, or let's say a Japanese knee or a Korean knee, will be probably covering more than 2/3 of the condyle. Whereas if I look at the population that I'm looking at over here, it's more of an Arabic population. These knees are huge. You go to the African population, these knees are huge. So 4 centimeter lesion in that size of a knee probably will still be somewhere around 2.5 to 3 centimeter lesion for an Asian knee. So what I would suggest is that rather than putting this kind of a classification, and still the world today is going by these sizes. So we need to understand that if the defect is covering less than 1/3 of the condyle, is something where you can really be comfortable putting an OATS over there. Anything more than 50, 55%, 60%, it would be little uncomfortable for you, because first of all, there is limited option. There is limited graft available, because donor sites are very limited. So you can not get a lot. So if you're finding the lesion is getting larger and larger in respect to the knee, because that is the area that is going to be the weight bearing area. Let's suppose a medial femoral condyle, 4 centimeter lesion in an Arab knee, I would still prefer, because that knee is a larger knee, I would get more grafts from these sites, and I can put, instead of 5 or 6, I can get 8 grafts from there. If I go to the intercondylar area, I can get 1 or 2 or more grafts. So again, I said, up to 1/3 of the size of the condyle is where I would be very comfortable putting it. Anything beyond that, I will be not in my comfortable zone.
So that 1/3 is the weight bearing portion, not the whole condyle. Yes. 1/3. So only the weight bearing portion, 1/3 of that.
Yeah. So wherever you got the lesion, so you measure the width of that condyle, and if that is, mostly we do it for weight bearing lesions. For something for trochlea, yes, it will not be trochlea can take in larger grafts, but again, because you are in the trochlear area and your graft harvest is from a very nearby area, again, those you'll be confluencing the areas, you'll be having lesser space, you'll be having lesser normal cartilage margin between the trochlear area. So again, any area which you're doing, especially in the weight bearing areas, 1/3 of the condyle space is what I would be very, very comfortable putting it, irrespective of the ethnicity of the patient.
So typically the OCT have been described for the mid-sized lesions, what we call. But if you say 1/3 of the condyle, it becomes like a large, very large lesion. So you say you are very comfortable treating the very extensive large
If
lesions with the
you,
OCT.
yes, I would be comfortable. If you say by absolute terms, I would be comfortable going up to 3.5 to 4 centimeters in absolute terms.
That is centimeter
But again,
square.
yes, but those absolute terms are absolute. Again, you need to understand from the point of view of the size of the lesion and what is the width of your condyle. If the width of the condyle is bigger, probably you can go in absolute terms a little larger. But if the width of the condyle is smaller, then again 4 centimeter is something which will cover more than half of the condyle. I would not be comfortable doing that. But
So
yes, generally now, sorry.
what is your preference? Like doing a mosaicplasty, harvesting a smaller multiple plugs or a larger, less number of plugs?
So as I said, I would prefer to go up to 80% coverage, 75 to 80% coverage of the surface area. And my first preference will be any plug up to 8 millimeter size. I'll try to finish up my surgery with 8 mm, because smaller plugs, again, once you take in smaller plugs, the harvest and the implantation is more, because the plugs are fragile, they are smaller. So your chances of injuring the plugs is higher. So getting a larger plug probably would be my tendency to go ahead with a larger plug. So 8 mm is the size that I would choose. And if I find that I'm not covering the area, probably a 6 mm plug would fit in there.
So how many plugs that we can harvest? Maximum plugs, suppose it's an Indian or your UAE
6 to 8
means the Arab
plugs.
population.
6 to 8 plug.
8 plugs from where? From where?
From the medial and from the lateral. From both the sides
From
you can
both
harvest
the
them.
side you can harvest. Suppose there is a kissing lesion on the patella as well, then
Sorry?
like suppose there is a kissing lesion on the patella as well. There is a lesion on the medial patellar facet. So what is your preference, from the medial side or lateral
Then I'll
side?
go from the lateral. Then I'll go on the lateral side. Preferably on the lateral side. Obviously, you don't want a kissing lesion. You don't want to increase the contact stresses over there. So you would definitely go on the other opposite side. And if I go on the opposite side and if I find a kissing lesion on the medial side, and I've got a medial femoral condyle lesion, and I've got limitations of the plugs that I've got. So again, even before you plan for the surgery, a complete arthroscopic evaluation of the patient is very important. And you need to, as I said, you need to make a mental map as to where you're going to get the plugs from, where you're going to fit the plugs. And probably you should be even somewhere a little bit open to, kind of change your strategy intraoperatively also if you want to. Or you should be open to go in an open procedure and try to find plugs from different areas.
Dr. Rahul, have you harvested plugs from the notch, the sulcus terminalis area?
I never required to harvest. There was one 6 mm plug that I had to harvest. Most of these cases, will not be pure osteochondral lesions that will come to us. They will be associated with some, meniscal injuries, or they'll be associated with some ligament injuries. Again, you are going in the notch area and the notch is not very good. So, the quality of chondral material that you will get from the notch probably, and again, getting from the notch is another issue, because again, that's a little difficult place to get because you'll leave an uncontained lesion in the notch again. Because if you're taking from the medial or the lateral, you'll have a contained lesion there. You'll have a very good shoulder around the harvest site. But in a notch, probably you may not have a contained area. Probably one of the areas of one of the borders or the margins of the notches may remain open. So my choice over there for notch, I've not done many cases, but yes, we had to harvest some smaller plugs from there when we fell short of the graft material.
So Dr. Rahul, recently we had the master class of cartilage repair in Ahmedabad, and you were also there. And we had a discussion. Dr. Deepak, he discussed that he takes 3 plugs maximum, and usually is very happy treating the lesion which is 1.5 to 2 centimeters square. So what is your take on that? So you are saying you can take even 8 plugs, 8 millimeter, and we discussed there that we can take 3 plugs max.
Yes. So again, as I said, the general talk in the world is going towards treating chondral lesions of a smaller size with an OATS. But if you go back and the video that I showed, which I borrowed from Dr. Hangodi, these are sizes up to 6 centimeter, 5 centimeter squares, and all of them have done well. I don't support that you need to go in a larger size, but yes, 3 to 4 plugs is what you would aim at. But again, it's an open discussion. If you look through the literature, you will find that people have been using for more than up to 7 centimeter, 8 centimeter square lesions are also being taken care of with OATS, and a mixture of OATS and osteochondral allografts.
So is there any study available regarding the treatment of large lesion with OCT?
Yes, there is studies. There are studies over there. I mean, you can go back and look at Hangodi's paper. Hangodi, initially they came up with up to 2 centimeter square lesion, because I think so the maximum work that has happened I mean, he was the developer, he was one of the earliest proponents of, and he still is the strong believer in that. So they have gone up to 7 centimeter square lesions also. I'm talking about absolute terms, but if you look at the European knees, especially the Hungarian knees, those are bigger knees. So again, in absolute terms, 7 centimeter squares, but in relative terms, yes, they have gone up to that level. You can find, if you go through the paper, which I showed at the last, that those papers can show you that there are larger lesions which have been done. Again, we are not saying that the results, but if you look at a perfect result, somewhere 2 to 3 centimeter, 2 centimeter squares is where you get a very beautiful perfect results with 2 plugs, maximum plugs.
So there might be smaller studies with the treatment in the large lesions, but if we say general recommendation, it is for the mid-size lesion, 1.5 to 2 centimeters square. That is there.
Dr. Rajat, if you look at the literature, you'll find that people have been pushing the envelope to a large extent in all arthroscopic surgeries. I mean, there are people who are saying that the scaffold works for even 8 centimeter square lesions. These are studies. As you understand, science is a growing thing. And research is something that people will try to push the limits and boundaries of research. So we should not look at it from a very microscopic point of view. We should understand that there are people who have done the work. We should go back, read their paper in detail, and try to take whatever we can take comfortably from that. But generally, the indications are these, as I said, and the ICRS has also come up with a large algorithm for treatment, which says that you have to use it up to 2 to 4 centimeters square. That was my first one of the first slides that I showed you, that it is up to 2 to maximum up to small to mid size. Now that small, mid and large is 2, 4 and 6. Yeah. So then again, as I said, there are people who are doing up to 8 centimeter squares. I mean, I saw Professor Hangodi myself doing it for a huge lesion. I mean, more than 50% of the condyle was gone. And instead of doing an allograft, he did an autograft. And those patients are doing well. So we need to understand, we need to look at it closely, and we need to understand what our capabilities are and how much we are comfortable doing it with, given the fact that cartilage science has expanded and we have got better options available now. And as I said that, the skill sets are also improved now.
So
thank you very much, Dr. Rajat. Rahul, I think, they were very good discussions. For want of time, we need to move on to the next presentation. We have Dr. Ilona, senior cartilage researcher from Lithuania. Dr. Ilona, can you please introduce yourself?
Yes, of course. But first of all, I want to thank you, the Indian Cartilage Society, for inviting me to give a presentation. And it's a very good opportunity, and I really appreciate this invitation. I'm Ilona Uzieliene. I'm a senior researcher from Lithuania, from Vilnius, from the Center of Innovative Medicine. I work at a research group from the Department of Regenerative Medicine. So the major field of my research is cartilage biology and cartilage regeneration techniques. So we are using different types of approaches that could possibly stimulate and regenerate the cartilage in vitro, and later on can be translatable into the clinics. So we work with different types of stem cells, including the bone marrow stem cells, the adipose tissue-derived stem cells, menstrual blood stem cells, and more. We're also applying different types of scaffolds, including natural and synthetic scaffolds, which we use as a 3D materials for the cells to differentiate into chondrocytes. And of course, we also use the native cartilage tissue that we receive from our local hospitals for evaluation of different drugs, and that we can also test their mechanical properties and the integration of our developed systems with. I'm a member of ICRS Communication and Publication Committee, and also I'm a member of European Cost Actions Network, which deals with osteoarthritis. So I'm pretty much into cartilage research. However, I'm not an orthopedic surgeon. So just in advance, I want to apologize for my basic science presentation, but I hope that it'll be interesting for everyone. So can I continue with the presentation?
Thank you so much. Yeah, please go ahead, Dr. Ilona. Sorry.
Okay.
Thank you so much, Dr. Ilona. I'm sure we have a lot to learn from you, being a basic science researcher. Over to Dr. Ilona on her talk on graft integration and biomechanical properties of osteochondral transplants. We need to understand what is going on the background after we do the transplant and how they heal and what are the biomechanical properties of these transplant grafts. So it is very important to understand these things, and this is where this presentation comes in. Over to Dr. Ilona.
Thank you so much, Saseendar. So today I will speak not only about the OATS, but about different types of biomechanical properties and the grafts that are being used inside the clinics and that are being developed in the clinical universities or research institutes. Of course, first of all, I will start with the problematic of osteochondral defects. We all know that cartilage has a very low ability to self-regenerate. So having the defect inside the cartilage, so it causes a lot of different troubles. And of course, it is most common in athletes and in elderly population, and also in youngsters that do a lot of tricks. Usually, if it's not being cured or repaired properly, these defects lead to such vast diseases as osteoarthritis, which are very common nowadays, and the burden of OA grows, and a lot of people suffer it in the world. So getting closer to the mechanical properties, I need to mention that mechanical forces that exist in the joint, so it's not only the compression forces, it's also the shear stress, the tension, the hydrostatic pressure. And under physiological conditions, mechanical load experienced particular cartilage is from 0.5 up to 10 megapascals. So it usually corresponds to approximately up to 20% of deformation of cartilage tissue. So mechanical load is actually not that bad to the cartilage. So we all know that it plays a very crucial role for maintaining chondrocyte homeostasis. It ensures the fluid and nutrient exchange, and of course, it stimulates chondrocyte proliferation and the synthesis of extracellular matrix. And of course, the excessive mechanical load, it brings us a lot of troubles like reduced chondrocyte proliferation, induced apoptosis, and also defects like traumas. So getting closer to the methods that are being used to repair it. So first of all, I want to thank Dr. Rahul for a very informative talk on OATS. It was very interesting for me as a basic researcher, but we do know that allografts and autografts, so they are one of the best decisions that are being used by the clinicians and orthopedic surgeons, because these methods had a lot of advantages. So, for example, autografts, they have no risk of immune rejection, they have good integration, cost-effective, while allografts, so they are available for larger grafts and no donor side morbidity, and also suitable for large cartilage defects. However, these grafts have also some disadvantages. For example, autografts have limited donor tissue availability, risk of donor site morbidity, while allografts have risk of immune rejection, potential for disease transmission, and more. But getting closer to their mechanical properties, what is very important to mention is that osteochondral allografts or autografts like Mosaicplasty, so they match the mechanical properties of the native cartilage tissue and subchondral bone, because, well, basically this is the same material that is being subjected to the same mechanical load. So it's very important that they fully integrate to the cartilage tissue. Of course, there are some failure rate up to 30% in the first 10 to 15 years. Usually it is due to biological integration, vascularization, and etc. So the factors that usually affect the mechanical properties of OCAs is, of course, the preparation of allografts. So we know that fresh allografts generally maintain the better mechanical properties, while the frozen or freeze-dried allografts, so they are dehydrated, they contain less water, and so they're being more fragile. So proper storage conditions are very critical to maintain and the biomechanical properties of the grafts. Now, getting closer to the OATS, we know, as Dr. Rahul already mentioned, that we can have a couple of Mosaicplasty grafts, and their mechanical properties are very comparable to the native cartilage. Sometimes there are literature that claims that gaps between the plaques can lead to uneven stress distribution, and which might lead to the further defects. While minced cartilage, which is not fully linked to osteochondral defects, but still reconstructing the cartilage itself, the minced cartilage usually lacks the mechanical stability, and this is due to the small portions of cartilage that needs to improve over time and build up the extracellular matrix around them, and by cells, of course. So now, what is being made in the scientific world to replace and have some alternatives to allografts and autografts? Of course, these are the scaffold materials that are being developed and are being used all around the world. So these materials can have both natural synthetic materials or can be combined. So natural materials usually have collagen, alginate, hyaluronic acid, gelatin. Synthetic materials are usually made out of polymers, and their combination usually is the best choice for osteochondral defects. So both of them have their own advantages and disadvantages. For example, synthetic materials, they have very high mechanical stability and strength, but they lack biocompatibility and biodegradation. While natural materials, such as, for example, hydrogels, so they are very compatible, they biodegradable, but they lack the mechanical properties. So usually they're being combined, and you definitely know the commercially available constructs like Mayo region or Cartilage. So they are made precisely for osteochondral defects, and they perfectly integrate into the tissues and rebuild it. However, they still have their own drawbacks. So the materials, they lack the mechanical properties, the ones that the cartilage and the bone itself has, because of their fibrous interaction. So, and how to actually avoid that and how to deal with that. So we know that cartilage has its own fibers of collagens and proteoglycans, which are arranged equally, and they're very arranged the way that they should be in the tissue. So in order to maintain those beautifully arranged fibrins, the developed scaffolds, they should be also mixed together with cells and tested mechanically in the lab. So in that case, the cells, they will restore the extracellular matrix around the scaffold tissue, and they will build the collagen network, the ones that is required in the cartilage and in the bone. And the cellular therapies that are being used for the developed scaffolds, of course, one of the major and one of the main cellular materials are bone marrow mesenchymal stromal cells, because they're closely located to the cartilage and bone, and of course they perfectly differentiate into bone and cartilage tissues. So they can be implanted or embedded into the scaffolds or directly injected. We know that the direct injection sometimes have a loss of MSCs and leakage from the cartilage joints. So implanting them into the scaffolds is a nice decision. However, sometimes we can also face immune reaction, difficult processing. Another alternative ways are, for example, having the scaffold 3-cell approaches, like you probably heard about the bioprinting technique Cyfuse, which combines only cells together and lets them grow and mimic cartilage without any additional synthetic materials. But coming back to the organization of collagen fibers and other biomolecules in the cartilage, as I mentioned already, they're very arranged. So in order to mimic that, we need to definitely test and replicate that into the lab. So a lot of different approaches and a lot of laboratories outside, so they work towards this question. And there was a group that published a paper in Nature 10 years ago. So they were testing the GELMA, which is gelatin metacrylate scaffolds together with cells which were placed on polycaprolactonic scaffolds, and they were trying different types of porosities in order to mimic the native cartilage tissue. And so they were also applying the mechanical load to these different scaffolds, and they understood that if GELMA had the porosity of 93%, so their properties are very, very close to native cartilage tissue. And so these electrospoon polymer fibers give even 54-fold increase in mechanical properties. So it is very important. These studies are continuing, and scientists are working towards recreating and mimicking both osteochondral tissue properties as much as they can. So for that, different techniques for testing mechanical properties of the grafts and developed scaffolds are being used. For example, there are developed biotribometry systems that are in AO Foundation in Davis and also in Rush University. So these machines, they allow to test not only the compressive load to the construct, but also the rotation, flexion, and recreate all of the movement that is happening inside the joint. So in that case, we can test, for example, the developed scaffolds or the native tissue, for example, if testing different types of drugs. And other machines like cell scale system or Flexcell technology, so they also allow the compressive forces to test on your developed in a lab scaffolds. So in our laboratory, we're working with stem cells, as I already mentioned, and we are applying different types of hydrogels and scaffolds. So here you can see the chondroitin sulfate-based scaffolds, the hydrogels that we were mixing together with cells and trying to stimulate their chondrogenic potential. And applying the mechanical load, the cells actually produced collagen networks and other cartilage extracellular matrix proteins more frequently. And additionally, we're also working with minced cartilage inside the lab. So we are doing different approaches like, for example, cartilage model testing for different drugs or different molecules that are being developed. So we also apply the minced cartilage to our Flexcell system, which is the mechanical load compressor. And we then see and evaluate how the tissue changes due to different external or internal stimuli. So basically, I want to conclude my talk that osteochondral grafts definitely remain a very valuable option for treating cartilage defects. And we definitely need to keep in mind their biomechanical properties before we introduce our developed materials into the clinics. So with that, I want to thank my team and our lab, the Department of Regenerative Medicine. So with their help, we're doing a lot of good work to the world. And thank you for your attention, and I'm looking forward to have some questions.
Thank you so much, Dr. Ilona. That was a very elaborate presentation. We could get a picture of the biomechanics of cartilage lesions as a whole and various methods of cartilage reconstruction. Thank you so much. There is one quick question. As far as are there differences between autologous chondrocyte plug transplantation between an autograft and allograft, other than the donor site morbidity? As far as the healing is concerned, do you think there are certain differences?
Well, to be honest, there are differences, of course. Using the same material from the same donor is always a better option. But for example, speaking about autografts, like the plugs, the Mosaicplasty, so we know, and Dr. Rahul mentioned that it is the most common and a better option for young people. However, the traumas are also being faced by older population. So, and it's not a perfect option for them. So they need to have the allografts. In that case, of course, it should be tested, but there are some risks that there will be some, immune reaction or some, I don't know, improper healing with those allografts, as I assume.
Dr. Rahul, do you have experience using allograft for osteochondral plaque transplantation?
Used allografts on a large scale, but probably when we had to do a bio-uni, we had very few cases of bio-uni where we had to use the bio-uni, and obviously that is a fresh frozen kind of a condyle. The patient has been followed up for at least up to 2 years, and we have not found any marrow changes or any reduction in his improvement. So probably, I think so, even the US is the largest user of allografts. And I think so there are a lot of studies coming out that usage of allografts has no contraindication. But the only problem that happens is that it needs to be a fresh frozen one. It needs to be easily accessible. And one of the reasons that probably it's not getting a lot of acceptance is because of the high cost involved in that. So I don't think so there is any major contraindications towards using allografts. And I don't think so there is any major osseous integration problem. But we need to understand that, probably it should be from the same ethnicity, which we cannot always guarantee. But yes, other than that, probably should not be a major problem of using allografts. And I think so, if you have got larger lesions, allografts is a good option in such cases.
So, Dr. Ilona?
Yes?
My question is that, is there any histological difference if you use a autograft or an allograft? So is there any study histologically which suggests that the superiority of OCT, the autologous or versus the allograft?
To be honest, I didn't check the histological differences between the two, grafts, but as I assume there shouldn't be any particular differences between them, because the structure of cartilage in humans, it's more or less the same, so it should be very similar.
Yeah, I do understand that it should be similar. There wouldn't be a major problem in the histology. You just need to be careful about any cell senescence or cell death, because the chondrocytes are very few even in a native cartilage. So there should not be any cell senescence which is happening due to the storage problem. So I think so it's the maintenance of the logistic chain that is more important in giving us a good osseous integration and a chondral resurfacing in case of allografts. It's just the maintenance of the logistics, the cold chain, and how it is transported and how soon it is harvested. Those, I think so, are the technical challenges. Other than that, probably there shouldn't be any. But my personal experience in this is not very high, so I may not be the best person to comment on it. But yes, the research shows that it is a good option.
So, Dr. Ilona, I think it's a good point to discuss. And you being a research scientist, you can search for the literature, or even you can do a study whether there is a histological difference between the allograft versus the autograft.
Yeah, I definitely can do that. So I'm interested in that as well. But to be honest, I'm not even sure if, there definitely are papers that are comparing these properties, but I'm sure there won't be many of them.
Okay, one question to to Ilona. It's an open question, even Dr. Rajat. I've always thought about this. I don't know whether it's the right thing that I'm thinking or not. Is that we are harvesting the cartilage from a low load area. I mean, the compressive forces on the harvest site, on the donor site, are very low. And we are putting that cartilage in an area where the compressive forces, the shearing forces are very high. Would that somewhere affect the long-term outcomes of our, I'm talking about 15, 20 years, although all the patients are not very satisfied with this procedure over a long term, but would there be any difference because of the fact that, I'm talking from the point of view of histology and the point of view of arrangement of the fibrils, collagens, and the arrangement of the and the distribution of the chondrocytes in the multiple layers, because we are harvesting it from a low contact pressure area to a high shearing and a high loading area. Is there anything that just comes to your mind from that point of view, Ilona?
Yes, thank you very much for this question. So to be perfectly honest with you, the area that is being subjected to less mechanical stress, so it's very similar to the area that is being subjected to more mechanical stress. So we can see that from different studies. So of course, we don't have any options rather than take the autografts from the places that is being more or less in a good quality and condition. So actually, it's the similar thing happens in our laboratory. For example, when we receive the clinical material from our hospital, so those are the joints that are after joint replacement surgery. So they're more or less don't have any cartilage at all at the places which is being subjected to mechanical forces. So we're harvesting chondrocytes also from those places that don't deal with any mechanical compression. So and still those cells they are being affected by mechanical load. So I would say that it shouldn't be a lot of differences. Of course, those places do not have that much of mechanical load during the lifetime, but still they are very similar to the ones that are being subjected to mechanical forces. I think the layer of the cartilage there is thinner, as it is like biologically, anatomically created. But still, there are a lot of studies that even use the nasal chondrocytes for creating the scaffolds for those places which are being subjected to mechanical load, and they claim that the results are very amazing. So let's hope that this is true, and I think that. But I was reading a lot of papers that autografts, so they remain for a very long time. And so people, some of them, of course, are probably not happy, but the others are. So probably depends on how you put them in. So.
Yep. So Dr. Rahul, excellent question and food for thought. I think if I say, as for the evidence available, I cannot say whether the cartilage which is transferred from the low weight-bearing area to the high weight-bearing area, whether it responds to that load or not. But as per my personal clinical understanding, if we see the natural cartilage, where the forces are maximum, the cartilage is quite thickest. So if we see the patella at the median ridge, the thickest cartilage is approximately 8 millimeter, and in the femur condyle it's 4 to 5 millimeters, and on the periphery it's 3 millimeters or even less. So it responds to the stress which is there. So if we see the wool slope, that is for the bone. So the new bone formation, it occurs around the line of the stress. So similarly, so if there is a constant stress, gradual stress on that cartilage, I think that grows. So if even we have seen your case, so in that case you have shown as the image where there was not a proper even coverage of that defect, and also we have seen that there were areas and there was also subsidence. So but if you see the MRI which is there on the post-operative, you have done it 1 year. So there was some integration, there was some cartilage growing. So I think that cartilage, that osteochondral plug, also responds to that stress. But we do not have the evidence available in terms of the histological studies or the long-term functional results. But if we look at the MRI pictures, I think they respond to the stresses.
No, Dr. Rajat, I do understand that, yes, the MRI, if you see, that responds very well. But the issue is that with the MRI, what is very obvious on the MRIs is that we see the integration of the subchondral bone. And the subchondral bone, as we know, a fracture heals. So subchondral bone integration, it will always be very good. But we do not know whether the cartilage that we have put in from a 2 to 3 mm area to a 4 mm area, will that cartilage hypertrophy because of the loading, and will it come back to that same 4 mm level? This is what something always was on my mind when we are doing this. But when I went back to Professor Hangodi in, I think so 2017, 2018, and he said that it doesn't happen, but whatever you transplant functions very well. So as I said, a joint replacement lasts for not more than 20-25 years in the best of hands. If a cartilage procedure is lasting for 20 years, I think so we should believe it and go ahead with it. Whether it's a 2 mm to a 4 mm or a 3 mm to a 5 mm, it works. And I think so. There was some paper by you also, Dr. Rajat, in the last conference where you showed about patellar defects also. And even in those cases, although the results are not as promising as in the condyles, but even the patellar defects with OAT works well, where there is a big mismatch in the subchondral plate and the thickness of the cartilage. So I personally don't think that the cartilage hypertrophies over a period of time, but it's the subchondral bone integration which holds it in place and gives it a smooth gliding surface.
I think we need to study more on this.
Yes.
Yeah, I think with the availability of better MRI options and cartilage-specific MRI options, there is a good scope for trying to understand whether the cartilage hypertrophies or hypertrophies tries to match the surrounding cartilage or and the subchondral bone, whether it tries to match also. I think that was a very good question and possibly an area for further research. That said, I would like to now invite Dr. Navin Tripathi. He is going to make a presentation on single-stage ACL reconstruction with arthroscopic mosaicplasty for large osteochondral lesion of the medial femoral condyle. Dr. Navin Tripathi, can you introduce yourself before you start your presentation, please? Dr. Navin.
Yes.
We can see you clearly.
Okay, just a second.
Meanwhile, we is connecting Dr. Navin Tripathi is from Nepal. He's a young orthopedic surgeon. He is going to present his case on ACL reconstruction with a large osteochondral lesion.
And I would like to add this to the viewers also, that probably Nepal was not a place where cartilage science had percolated down as it has in India or probably in the European and the American world. But because ICS offers a lot of fellowships, I'm really happy to see that Dr. Navin, after completing his fellowship, went back and had the technical know-how and the skills to probably proceed with something like this. And I mean, we should really take it in a good stride that Dr. Navin learned from the ICS, learned from the mentors of ICS, and went back and utilized his knowledge and his skills and his learning from there and did the first case over there. So we would like to see your case, Navin. Please come online fast.
It's a proud moment for Indian Cartilage Society. Now, after learning, he is also here to share his experience, and there is a lot for us to learn from him now.
Yes, surely. And probably, as we had the vision that, cartilage science should percolate to the surrounding countries, probably Navin has taken the torch and, done it over there. So good. Navin, can you start sharing your screen, please? We are waiting to see your work. And Navin is from the... Is he?
Yeah. Actually, he informed me that he had some glitches, but he's trying to share his screen.
Okay.
Can you see me, sir?
Yes, please.
Yes, we can see you.
The problem is I'm not being able to share my screen. I just connected from my mobile. I wanted to connect.
So meanwhile, we can take the questions to Dr. Rahul while you are trying to connect. Okay. So Dr. Rahul, you have mentioned the Hangudis paper. So, if we review the Hangudis paper done in 2008 and also he's done some studies in 1996 as well. So he has used the size which is less than 4.5 centimeter square, and he has used the plugs 6.5 millimeter square not more than 5 plugs, and he used it for the different side, knee, ankle, and the other side as well. He's used it for different joints, but the largest size of the lesion which was there in his study was 4.5 centimeter square. He has used 6.5 millimeter, maximum number of plugs of 5. Even if we review the recent literature, even the Dr. Deepak Goyal's recent review about the size of the cartilage lesion, and even if we take the Indian Cartilage Society consensus done in way back in 2015. So, if we conclude all of the things, it is the small and mid-sized lesion of 1.5 to 2 centimeter square in most of the studies, and only the Hangodi's paper, the maximum size and the maximum number of plug were 5, the size were 4.5 centimeter square. So more than that, there is no such literature that suggests use of the osteochondral cylinder transfer for a large size of the lesion.
I do understand that, Rajat, you're trying to pin me down to follow the ICLR. I do understand that you've been constantly going back onto the same question, but as I said, that
the message to the young surgeons should be very clear.
Exactly. So
that is my whole purpose, that there should be a clear message to the young person that if you see a very large lesion, 3 centimeter, 4 centimeter square, you should not rush, going to the OCT.
No, I do understand that. That definitely there's a huge body of evidence which says that it is small to mid-sized defects. I mean, I wouldn't suggest anybody who's not well versed or deeply entrenched into cartilage science to go somewhere beyond that. And again, a lot of algorithms have come out which say that it is small to mid-sized defect.
Yes, so because you mentioned the 8 millimeters, 8 plugs. So that is a huge, the cartilage transplant.
Yes. But again, as I said, that we as scientists and we as surgeons are always pushing the envelope. So this was for a mature audience that I was speaking on, but for a beginner level audience, or for if you want to convey a message, again, not more than 2 centimeter squares is what all the international papers suggest. Definitely not more than 4 centimeter. You would never want to go there, that area. Never ever in that area. If your actual final margins come out to be approximately 4 centimeter square. So again, it is very safe, very good for up to 2 centimeter. And again, I said small to mid-sized lesions, not beyond that. So I don't want the message to go out wrong, that we are telling them that you can use it in a larger size and huge defects. But yes, there are, if you see individual papers, short papers with decent follow-ups, people have used up to the full condyle has been used. A large amount of the condyle. But again, this is for a mature audience, not for a beginner audience. So again, I know you're...
Yeah, as you said, the rules are for the beginners. The experienced ones make the rules. So I think there was a lot of very good discussion on the pros and cons of using it for smaller, mid-size and large lesions. And there is definitely a lot of take home to for everyone from it. Dr. Navin still has some issues in sharing his presentation. We will just have one more question, a couple more questions, and if Dr. Navin is not able to share, then we will have to have him later. So do we have any other questions for Dr. Rahul and Dr. Ilona?
So can we ask Dr. Navin to share the presentation to you? Then you can share it out.
Yeah, I tried that, but he has not been able to successfully send the email to me either. So he is finding difficulty, possibly network issue.
So Dr. Rahul, what is your take on the treatment of osteochondral lesion of the patella? So I have done the studies on the patellar osteochondral lesion treated with the OCTs. What is your take? How do you manage them?
So again, patella is a different beast altogether. You need to understand that it's different. The surfaces of patella are completely different. It's a concave or convex with a median ridge present in that. So and again, the patellar thickness right in the center is different. As you go off towards the lateral facet, the patellar thickness reduces. The medial facet has got a good thickness of patella. The subchondral bone is a different thing. OATS is a decent procedure for small to mid-sized lesions again in the patella. It's an open procedure. There have been certain video techniques, and I was really intrigued by one of this video technique, whereby some researchers or some surgeons from South Asia, probably from Korea, had used an all-inside, if you are familiar with the all-inside flip cutter that we have for the ACL to create tunnels, they have used those to do an all-inside and arthroscopic, even patellar OATS procedure. It was a technique presented, I think so in 2023 or 24, early 24. I have not followed up that for a long time. But again, patella, you need to understand, you need to see what is the tracking. Most of these chondral defects are associated, if they are not traumatic chondral defects, many of them are associated with certain maltracking of the patella. So the alignment, the tracking of the patella has to be first very carefully understood. You need to do all the radiological indices of the patella, the Caton Deschamps, the install solvity, the Blackburn Peel index, the TTTG distances. All those need to be understood, because just treating the patella chondral defect as an isolated thing probably will not work, because the forces on the patella are very different, and they are different during various stages of flexion. So that is where you need to kind of understand. OATS is a good option for probably somewhere in the medial facet to up to the ridge. Lateral facets are smaller, thinner. The subchondral bone is not very heavy. So you need to tailor make your plugs to not a 15 mm plug, what we regularly would want to use for our condylar defects, but you would want to tailor make it to a shorter plug. But again, then somewhere you feel that you're compromising the press fit stability of that construct. We have used it in even the lateral facet, but closer to the ridge, not way off onto the lateral, the part that articulates with the lateral margin of the lateral femoral condyle.
So excellent answers, Dr. Rahul. Regarding the biomechanics, I think the patella, the five forces are quite different, as you mentioned, and we need to manage the biomechanics first. First, rehabilitate that patient, assess that patient really well, and also, it is very difficult to match the contour of the patella once we harvest the plug from the femur side, and it is also difficult to manage the thickness of the cartilage also, and
yes.
And also we need to harvest the plug which is thinner. So in femur OCT, we harvest the plug of 13 to 15 millimeter. The patella thickness is quite less, especially at the periphery. So we need to harvest a smaller plug of 8 to 10 millimeters, I guess, if we are doing for the female patella, especially in the Indian population that is having a very thinner patella.
Yeah, so if you go to the lateral facet of the patella, it's quite thin. The medial facet can accommodate up to 12 to 14 mm, but the lateral facet of the patella definitely is a different ballgame. So that's the reason why for patellar chondral defects, first of all, I would always want to go through a thorough radiology and a thorough clinical examination of the patient. One, to understand that. And secondly, my tendency, because now we have got certain scaffolds available, I'm tending more or leaning more towards the scaffold, especially in patella, because especially only for chondral lesions, I'm not talking about osteochondral defects, where you got a subchondral bone involvement of the patellar facets. So that is what my tendency has in the last 4 to 5 years. Probably I'm shifting more towards that side. As a single step solution, I can do it arthroscopically. The patient has no incisions and the patient is happy going back to his activity. But I don't know how these scaffolds will over a period of time survive, how they will do. I mean, that is somewhere, research needs to be more focused upon.
So Dr. Rahul, excellent point about the subchondral bone. So what do you think? What is more important, subchondral bone or the cartilage? You have,
I think
seen the discussion.
I think so both are important. I think so both are important.
Discussion in the master class between the
cartilage will not be there.
So they both are important, but I think
understand that, Dr. Ravi. If you got a cartilage defect, sorry, moderator, tell us.
Sorry. Unfortunately, Dr. Navin is not able to join us, so we will have to make do with the program so far. we will have to take up Dr. Navin during a later time.
Sure. Definitely. Not a problem.
There's no issue.
Okay.
So thank you everyone for today's presentations. Thank you, Ilona from Lithuania and Dr. Rahul from UAE for their presentations, sparing their time. I think the presentation were excellent and we had a quite good discussions as well. Unfortunately, we could not discuss the case presentation by Dr. Navin due to some technical issues, and probably we'll have him at a later stage. And thank you everyone.
Yeah, thank you so much, Dr. Rahul. Thank you, Dr. Ilona, for sparing your time. Thank you for all the hot discussions here, and hoping to meet you again later.
Thank you very much.
Thank you very much.
See you. Bye.
Thank you.